That's a tiny fraction. If we think the study one underreported, and showed a rate of about 6% of the kids having sexual abuse only, and yet only a quarter of those ever got help, that says there's a lot of people out there. As has been reported here, the health impacts on victims are massive. We know we see greater gastrointestinal problems, reproductive health, and GYN problems among women. Also significantly, we know that victims of sexual abuse use a lot more health resources than other people. And there's every indication from the research that they, however, use it in a more emergency and crisis-driven way. So they use it poorly, so they consume a lot more, but they're more likely to use emergency rooms and other sources of that, like that, which are relatively ineffective, don't help establish a relationship with the provider, and are expensive. As has been noted, the mental health problems include post-traumatic stress, depression, anxiety, suicidal ideation and behavior, substance abuse. Most sexual abuse, and our studies confirm that, I'll talk about them in a moment, show that abuse occurs before adolescence, and the vast majority of kids, it's pre-puberty. But the consequences express themselves during adolescence, as kids become aware of who they are and as they become sexual beings and so on. And we see poor self-esteem, eating disorders, has been reported, obesity, and compromised functioning work in schools and in intimate relationships. Smoking, alcohol, and drug use have been mentioned. Earlier intervention of IV drug use has been seen in some studies. So among teens who are using drugs, much more likely early to use IV drugs, IV heroin. And also weapon carrying, which people don't associate with abuse, but there are studies that suggest it's associated with weapon carrying. We do know that teens with a history of abuse are more likely to start having sex earlier than non-victims. They're likely to have more sexual partners. They're likely to be less self-protective, so the use of contraception, of condoms. And one study has suggested a causal chain between childhood sexual abuse and a range of high-risk behaviors and an increased risk for early pregnancy. So some of the costs may not express themselves in terms of the treatment of victims and the prosecution so much as in pregnancies, and we know teen pregnancy is a very expensive phenomenon. Teens who keep their children have lifelong poor outcomes in terms of work and finances and so on. My own research has not focused on abuse, but on the environments, the risks, the coping, and worries that teenagers have. But in a study that I did of about 750 young people who were applying for our services but had not yet been seen, they had not developed any kind of trusting relationship with us, I found, without particularly looking for it, pretty high rates of abuse reported. 12% of the teens reported they had been forced to have sex. And of these, these teens were 3 times as likely to have used drugs in the last 30 days than teens who didn't report that experience. A similar number reported having been touched uncomfortably. And the drug use in these teens was similarly, it was about 2.5 times higher than in teens who did not report the experience. We also looked at the correlation between other bad outcomes for kids and abuse, and we had about 27 categories: school dropout, things like that, substance use. And kids with abuse, the abuse was associated with about 27 other bad outcomes. That's a high number. When we asked teens who were sexually active and had an abuse, we looked at teens who were sexually active. Those with an abuse history were far more likely to report that they used drugs and alcohol to make sex easier. That means they're therefore having poor decision making. They're again not going to use condoms and so on, because if they're high, that's a foregone conclusion. Now I'm here today after meeting with Assemblywoman Markey on behalf of a colleague, Angela Diaz, who is really an expert. She's the director of our center and is an expert on adolescent health, and has done a lot of research on sexual abuse. And she's speaking elsewhere today, but I'll touch on her research a little bit. We provide services to about 10,000 young people every year, health services. So we see a lot of kids. We provide physical health, mental health, and so on. And the kids who come to us are primarily poor and most lack insurance. Without our services, they would not have a place to go. So when Dr. Diaz got interested in the phenomenon, she asked a number of medical students who were doing a study just to simply ask kids who were there for routine physical about sexual abuse history, and we found 27% said they had had a history, just being asked in the physical. We'd never asked before. This is in the 80s. As somebody pointed out to me not long ago, physicians ask, they check the ears on every visit, even though the rates of ear infection are probably, I think, 1 in 1,800, but they don't ask about sexual abuse. And in fact, kids on the Commonwealth report that I cited earlier, what those adolescents said is that their providers, health providers, mental health providers, failed to ask them about a whole range of behaviors, substance use, abuse, and so on, and that they would like to be asked. So we know that we as a profession are in some ways failing them by not asking. So we make it our business to ask. In one of the studies Diaz did at the center, 22% of female adolescents receiving routine medical care disclosed abuse when asked directly by the physician during the routine history. So this is a second study. Now, most of these patients, 90% of them accepted a referral to counseling, and about 81% showed up. So that suggests if you ask, if you have something in place, you can potentially help kids. Diaz did a secondary analysis of the Commonwealth study also of the 6,700 kids, and she found significant associations between abuse history, drug use, and eating disorders, as has been reported here. In another study, Diaz looked at quite broadly at the phenomenology of abuse, looking at who the perpetrators were, the age of the victims, the number of incidents, and so on. It's very telling. She found that the age of the victim when first abused ranged from 3 years to 17 years in this study. But most, 70% of the victims were under age 11, and the average age at first episode was 8 years and 8 months. For 20% of the victims...
Excuse me, that's in this country?
This is in our sample. 8.8 was the average, 8 years and 8 months. This was in New York City, our kids. 20% of the victims, the abuse occurred once, within 1 day, or numerous times within 1 day. But for many, it occurred over long periods of time. For 11%, it took place over the course of a year. For 30%, it was for more than 2 years abuse continued. And for 18%, 6 to 10 years. So these are not single events. We also know, and all the research shows, the longer the time frame and the more intense the abuse, the worse the impact is. And I'm sure you'll be speaking to that. One other little note I was just looking at as I was sitting here, the frequency of abuse. Diaz looked at the frequency of abuse by the first perpetrator. So where kids had, she simply looked at one perpetrator, whether it was a kid that had only one or it had numerous perpetrators. And we had 21% reported one episode occurring in 1 day. 9% reported abuse over about a month apart. This is the frequency of the abuse incidents as opposed to the time frame over which it took place. 13% reported about 1 to 3 times a month that they were abused. 31% 1 to 4 times a week. 20% 5 to 7 times a week. And 6% didn't remember. The other thing in my study that was interesting when we were asking kids about forced sex and being touched uncomfortably, 6% of the kids in the sample, again this was a sample of about 760 kids, said they didn't know. if they'd been abused. So we looked at that. We did some kind of, I had a statistician working with me who did some careful analysis, looked at outcomes for those kids compared to the kids who said yes, they'd been abused. And all of the psychosocial outcomes, the depression, the anxiety, and so on, were worse. So the ones who report they don't know are highly likely to have been abused, but they don't know how to define the experience.
Do they black it out?
We don't know. That was not something we looked at, and that is an old theory that people do that. We tend to think that kids don't. They just don't think it's safe to talk about it, or they're confused by the circumstances, or there's been an abuse of trust, has been referred to, that, and that is extremely damaging. I'll finish up. There's just a couple of things I wanted to mention. We also found that kids who'd been abused, adolescents who experienced child sexual abuse, were also likely to have other abusive relationships during adolescence. So, in both emotional and physical abuse. 1/3 of them reported that as adolescents they'd been victims of rape. So post-abuse, 1/3 had been raped as adolescents, and 1/4 were currently in an abusive relationship of some kind. These numbers are powerful, but of course behind all of these numbers is the intense pain that this experience causes. One other comment I wanted to make in respect to the question raised in the first panel is abuse is devastating for a family, whether the perpetrator is a member of that family or not. It really does destroy trust. It can cause irreparable damage. And in Diaz's studies, we found the kids had a very, very damaged sense of trust. The relationship with the mother was very damaged. Their ability to communicate with the mother, the amount of the runaway phenomenon that you see in the press was much higher. But I want to end by saying that as a professional with an investment in helping children and adolescents, and as a father of 2 girls, I've got a teen and a preteen, I appreciate the opportunity to be here today. I'm really grateful to you and to your colleagues for this opportunity and to have the courage to raise this. I think it's been overlooked. Thank you.
Thank you. Dr. McDonough? Excuse me.
Yes, hi. My name is John McDonough, and I'm a licensed psychologist, state of New York. I'm also board certified as a clinical psychologist by the American Board of Professional Psychology. And one of my specialties is doing trauma work, because I'm also certified by the EMDR Association. EMDR is a specialized therapy for trauma. We deal with a lot of trauma. I also am a member of the Soldiers Project. We see veterans of the Afghan and Iraq War and their families for pro bono. And so I deal a lot with combat PTSD as well as other kinds of PTSD. So I guess I'd like to begin my remarks by thanking Assemblyman Lental and his staff for inviting me here, and also special thanks to Assemblywoman Markey for not giving up. She's very persistent. I really respect that. So the gist of what I wanted to say today has to do with the concept of fairness. And what I would like to maintain is that the essential unfairness of the very short statute of limitations currently on the books in New York it's kind of a very sad, really outrageous irony that the ability of the sexual abuse victim to take legal action has actually been impaired by the sexual abuse itself. I mean, I think that is just outrageously ironic. And what I hope to show today is the ins and outs of how that happens and why that is. I'm going to depart from my prepared remarks because I think some of it has been touched on. In addition to hats off to Pennsylvania for having an age of 50, we just want to point out our neighbor to the east, Connecticut, has an age of 48 for the statute of limitations. Wisconsin, age 35. Maine has no statute of limitations for sexual abuse at all. And I understand the whole country of Canada does not either. So our tradition of jurisprudence does seem to be you know, it's not a one-size-fits-all kind of thing. So there's no reason I don't think that we can't, on legal grounds, you know, expand the statute. I think the other irony here is that if there's no statute of limitations